Hi, I'm Dr. Joe Smith from Atlas Health, and welcome to my Facebook Live broadcast. Today I'm going to be covering a topic that's a very common topic that comes up with the clients that I serve. It's why do I have thyroid symptoms even though my lab tests are normal? It's a huge question that I get, and we're going to talk a lot about thyroid physiology today. And today is kind of more of an overview of some of the different patterns that we see in the functional model, and I can do more specifics on each pattern on later videos. I'm basing this on a book written by a mentor, colleague, and friend of mine, Dr. Datis Kharrazian, called Why Do I Have Thyroid Symptoms Even Though My Lab Tests Are Normal? Okay, and it's a great book. So if you're looking for more detailed information on this, that would be, in my opinion, the best resource for you. I practice in Fairfax, California, which is about 30 minutes to 45 minutes north of the Golden Gate Bridge in Northern California. And the type of patients we serve are mainly complex cases that are kind of looking for answers. They often call medical mysteries, or they describe themselves as that. They've had some chronic condition that hasn't resolved, but they felt better for a while and they've plateaued, or they felt better for a while and it's come back, or they're never really been given a diagnosis and they're just kind of looking for somebody to walk through their case. And we do have patients that we see that travel in from all over the world, and we also do some consulting for folks that are able to take some information that we give them and still improve their quality of life. If you need to reach us or would like to talk to us after this video, the best way to do that is to go to our website, atlas-health.net. And also, if you want to email us, it's contact@atlas-health.net. And I'm really excited to be sharing this topic with you today because, you know, the common thyroid symptoms for hypothyroidism, the most common are depression, fatigue, constipation, and inability to lose weight. I mean, that's a huge, huge, huge percentage of the population, right? All these people out there that are depressed, are overweight, have done diet, done exercise, haven't been able to lose any weight, are having digestive disturbance where they can't move their bowels, or they have acid reflux or some other digestive issue. Maybe they have an unresolved SIBO, which is a small intestine bacterial overgrowth, or maybe they have other autoimmunity and the thyroid gland isn't working, so now that autoimmunity gets amplified, okay? But one of the main reasons I want to talk about thyroid today is because almost everybody that I see has one of the patterns we're going to talk about today. Now, not everybody, okay, but most people that I see, and the reason is because the thyroid gland releases a hormone called thyroid hormone, and its job is to set the metabolic rate of our tissue, meaning if thyroid hormone is low, then our tissue produces less energy and we don't heal, okay? So pretty much anybody with a chronic condition at all has a thyroid component to it. And I'll show you in a minute what I mean by that when we start drawing these patterns out. Now, I want to be pretty, I need to emphasize this point that I'm not an endocrinologist and I'm not a medical doctor. And so I legally cannot treat thyroid disease, okay? So what that means is if you are a person with primary hypothyroidism that requires a prescription medication, then I'll identify that pattern, but then I refer you immediately. Okay? If I see somebody with Graves type presentation, which is an autoimmunity to their TSH hormone, then I will refer out for management of autoimmunity related to Graves disease because that can be a life-threatening condition. So I'm a chiropractor. I practice chiropractic neurology. I also do a lot with clinical nutrition. And so this allows me to take a broader view than perhaps what the standard of care is. And we'll talk about the standard here in a moment. But I just want to be clear that I'm not licensed to treat thyroid conditions. And when we start talking about these different patterns and interventions, it's not to treat the thyroid, but to support the underlying physiological process that's gone awry, causing them to exhibit thyroid symptoms. That's a mouthful, but it's a big difference, okay? And the thing is a lot of people that I see are on thyroid medicine, and their lab tests look normal, and they still have thyroid symptoms. So in that case, what do we do? Okay, so if you're the person that's been depressed has been told you have hypothyroidism, can't lose weight, are constipated, are cold all the time. And if you look at the picture for this presentation that I'm doing today, or this live broadcast, that picture is thyroid symptoms. And so if you have those symptoms and you've gone to a medical doctor and they've already diagnosed you with primary hypothyroidism and they've already put you on prescription medicine for it, and your levels look better and you don't feel any better, then I think this broadcast is going to have a lot of information for you. And when we start working with these patterns, we're not treating the thyroid gland. What we're doing is we're improving thyroid function through assisting the tissue. And so that's a completely different model. So I just want to say that this model isn't better than any other model. It's just a different model. And so let's talk about some of the existing models out there, because I think it's really important to understand what's going on. So the average person walks into an office and say they're like overweight, they're not able to lose weight, and they're like, okay, I'm also a little depressed by that. And when they start asking questions, I'm constipated too. And the doctor might say, okay, let's test your thyroid gland. And what they're going to look at is something called TSH. And they look at one hormone, and then if TSH is normal, they're told they're fine. Okay? Or if TSH is abnormal, they're put on prescription medicine. And if the prescription medicine makes the levels look normal, then they're told they're normal. And if their depression doesn't go away or their weight gain doesn't change, then they're told it's not their thyroid gland. And maybe they just need to exercise more than they're exercising or eat differently, even though they're already doing those things. But they're not really given clues on how to exercise, and they're not really giving a diet that's specific to them. So they're like, yeah, just go exercise and eat differently. Just go do that. And they're like, okay, how do I do that? Well, just go do it. So the reason that, it was Jess Flanagan. I don't know if some of you are here because we do these videos with Jessica Flanagan too, but she had this idea of doing a Facebook Live event and interviewing each other, because she and I get a lot of the same questions over and over again. And we realize that so many people are looking for this information and they're just not getting it, except for, if they happen to come across a practitioner that knows this stuff. So the reason I'm doing these broadcasts is to help you answer some questions so that you can make an educated decision about what's going on with your life. And also for those of you who are told that you are just depressed and you need psychiatric medicine, so that maybe you have some more information so you don't feel like you're crazy and you need to be on mind-altering drugs. That's the kind of some people just don't like that feeling. Like my life is such that I need to take a prescription drug for my brain. And a lot of people are uncomfortable with that. And I'm not saying that that's inaccurate or they don't need it, but what I'm saying is if there is an underlying thyroid pattern that's undiagnosed and we work with that pattern and that pattern resolves, then the symptoms of depression may also resolve. That's not the same thing as treating depression through a drug model, which only can be done by a medical doctor. That's called supporting physiology, which functional practitioners can do. Okay, so that's just a long introduction to why I'm here today. And I really, 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 really earnestly hope that this is helpful information, because there's just so many thyroid patterns out there. So let me just talk a little bit about how to measure thyroid function. Okay, so I'm going to draw this on the board here. There's some hormones that you want to keep track of. So what happens is the brain has this little sensor called the hypothalamus. Hypothalamus is like a thermostat, and it measures the levels of thyroid hormone. And if the thyroid hormone goes low, it's like when the temperature in the room goes down, the thermostat kicks the furnace on. The hypothalamus releases TRF, thyroid releasing factor, and then it goes to the pituitary gland, and the pituitary gland releases something called TSH. TSH is like how the brain says, hey, thyroid gland, do your thing. TSH goes to the thyroid gland, and I'll just draw a thyroid. I'm a great artist, okay? And so the thyroid gland is right here. It's like right under the Adam's apple. It's kind of a little butterfly-shaped organ right here. It's pretty thin, okay? And the thyroid gland makes something called thyroid hormone, okay? And it takes 2 iodine plus 2 tyrosine, and it makes something called T4, which is thyroid hormone. Now that thyroid hormone is bound to what's called a binding globulin, and the enzyme that's used to make that is called TPO. TPO is what glues that together. Okay, Now, about 94% of the hormone that this is made here is T4. Okay, about 6% or 5% is something called T3, which is another thyroid hormone that we're going to talk about in a second, which is also bound. Now, what it's bound to is a protein called a binding globulin. It's kind of like the chaperone. So when you're taking your daughter to the homecoming dance, and then you're chaperoning her to the door, and then she gets safely to the dance, and now she's free to do whatever she's going to do at the dance, but she has a chaperone on the way. The binding globulin is that chaperone. So it stays with the thyroid hormone until it goes to like the tissue, like in the brain or your muscles or your heart, and says, okay, now that we're at the tissue, at the receptor, the binding globulin lets go. We don't know how that happens, but we know that it does. And then now the thyroid hormone is free to activate that tissue. We're going to get to the why we're going through the physiology first, okay? Because all these different patterns are based on this physiology. Okay, now in the thyroid, in the liver, this circulated T4 goes to the liver, and there's an enzyme here, and these names don't matter so much, but it's called 5'-deiodinase. It's an enzyme that converts T4 to T3 to something called reverse T3 and something called T3S and T3AC. Now all these are bound, which means they still have their chaperone with them. Okay? Now this one here, T3S and T3AC, goes to the bowel, and it gets converted to T3. So some people have a bowel issue where like their bowel is all screwy, it doesn't have the right bacteria in it, or too many bacteria, or not enough, or a parasite or something, and about 30% of the T3 gets converted there. So this is the person that has a bowel issue, that has a mild thyroid issue. Okay, and then we're going to talk about how we sort all this out here in just a little bit, but I just want to go through the physiology. Okay, now this T3, now that it's made, it's ready to go. The T3, which is bound, goes to the tissue, and there's a receptor, and this binding globulin goes away. Okay, so now it's free, and that free T3, it goes right up to the receptor, boom, and it activates the tissue, and the tissue has a response, and then what ends up happening is inside, if I was going to draw a little square here and make it bigger, inside that square in the nucleus, there's a little DNA response. So you've activated your genes based on your thyroid hormone. It's kind of cool. That's how it works. That's, in a nutshell, thyroid physiology. But why does that matter and related to this? Okay. So why it matters is, might we want to do more than just measure TSH, which is standard of care? Might we want to look at T4, the total levels, and then might we want to be able to measure the free levels of T3 and T4 without the chaperone? Does that matter? And the answer is yes. Okay, so people can have a problem with thyroid anywhere on here. Okay, and there's actually a way to go through, and we're going to start talking about that, to diagnose where the problem is with thyroid function by using history and by using mainly labs in this case, okay? But you can't do that if you only look at TSH, and that's the standard of care. Now, I see people from all over the world, and they're submitting labs to me all the time, and I'm going over these labs over and over and over again. And I can't tell you how rare it is for me to get a doctor that is ordering a complete thyroid panel so that we can see the whole picture. If you're missing any of these, with the exception of these guys down here, which happen in the bowel, then you're not going to be able to do a complete thyroid workup, okay? So that's part of the issue is, in order to diagnose this, the person needs to be thorough in their assessment, and then they need to be able to read the labs and make the appropriate diagnosis. I also want to say that there's something called a functional range and a disease range, okay? So most labs will say that TSH, for example, is out of range. TSH should be between, that's a really crappy marker. TSH should be between, we'll say like 0.5 and 4.5. Okay? Wow, okay, that's kind of a big range. But the Endocrine Society says that the functional range is 1.85 to 4.5, meaning inside this big range, there's a smaller range where there's optimal function. Okay, and so a lot of times people will come in and they'll have all the symptoms of thyroid disturbance, but their lab tests are normal based upon the lab range. But when we start looking at what the standard is by the Endocrine Society, it's a little bit different. Okay, and the other thing is this: lab markers. Do you all know where lab markers come from? So like if you do a blood test with LabCorp, where does the ranges come from? Like to say if you're within the range or outside the range in your lab test. Lab ranges come from an average of all the people in the area. Okay, so everybody in the area, that region, does labs, and then they crunch that data, and then whatever the averages are for that patient population become the averages for the ranges. Can anybody see a problem with that? Who's getting lab tests? Really healthy people that are going to the doctor? Or people that just aren't feeling very well? So isn't that interesting? Okay, you start looking at labs and go, wow, these labs are being compared to a population of people that aren't feeling very well, and I'm within that range of people that aren't feeling very good. So I guess my lab tests are normal because not too many people are feeling very good, they're getting lab tests, okay? But the reality is that within that big range of disease, there's disease and dysfunction, and that's where functional medicine doctors are doing a lot of their work, okay? So that's where I do a lot of my work, is when I see people that are outside the lab ranges and they need a referral for a prescription, then I'm obligated by law and ethically I would want them to feel better and not die and not get sick, so I would refer them to a doctor to get the appropriate treatment, okay? But for people that are out inside the lab ranges, and then they're in the functional ranges, but they're still looking for answers, then that's why this model of healthcare has developed. That's why it's evolved, okay? So that's the underlying physiology of the thyroid, and this is kind of where I'm coming from when I start saying I'm looking at ranges, okay? So to summarize the lab biomarkers that a thorough doctor would need to look at related to thyroid hormone, we need to see TSH, okay? We need to see something called total T4. We need to see something called total T3. We need to see something called free T4 and free T3 and reverse T3. And then we need to see something called TPO antibodies. And we need to see what's called thyroglobulin antibodies, TG antibodies. Okay, and if you've seen any of my other classes, antibodies are like this. You know, like I'm from the Midwest, they have these trees, Dutch elm trees, and there's Dutch elm disease. And so when there's a Dutch elm disease thing going on, the people will go by and they mark the disease trees with X's, and then a guy comes down and cuts the tree down. An antibody is like that tissue has been marked by that person, and then now the immune system has to come by and cut it down. And that's not a good thing necessarily to have antibodies outside of range. That's called autoimmune disease, okay? So let's get into some of these patterns, okay? So there's the physiology. The hypothalamus decides if there's enough thyroid hormone. If there is enough thyroid hormone, it releases something called TRF, which tells the thyroid gland, tells the pituitary gland in the brain to tell the thyroid to go to work. The thyroid takes protein and uses an enzyme to glue the protein together to make thyroid hormone. And then the thyroid hormone goes to the liver and gets activated to another type of hormone. And then that goes to the tissue receptor, and the chaperone lets it go. And now the receptor responds to the tissue, and there can be a DNA response, and the person makes energy and they're capable of healing. A person that has a problem in the brain could be a thyroid issue because now the thyroid doesn't get the signal from the brain. The person can have a problem making thyroid hormone. The person could have a problem with the amount of bound versus free thyroid hormone. The person could have a problem converting thyroid hormone into T3, and then the person could have a problem at the receptor. So let's say they have normal thyroid levels, the thyroid hormone goes to the thyroid receptor, but this receptor is like dumb, it doesn't respond. It's like, no, I don't want to do it. So then now the thyroid hormone docks there, and the DNA doesn't respond. And that's called a peripheral utilization issue. So let me just say that again. The brain senses if there's enough thyroid hormone And then it tells the pituitary gland to give a signal either, hey, it's really hot in the room, meaning there's a lot of thyroid hormone, let's cool out and not give so much directive to make thyroid hormone, which is made in the factory called the thyroid gland. Or the brain says, it's getting kind of cold in this room, there's not enough thyroid hormone, why don't we increase thyroid factory output of our hormone? And so then it tells the pituitary gland to tell the thyroid gland to make thyroid hormone by taking protein and gluing it together with an enzyme or a worker bee called TPO. That's this guy. Okay? Now, what are the different patterns? Okay? Now, what I want to do today is kind of an overview, and I'm going to go through these patterns quickly, but I want you to know that I'm going to spend a whole 30-minute section going over the patterns in the brain. I'm going to spend a whole 30-minute section going over the patterns in the liver, and I'm going to spend a whole 30-minute section another time going over the patterns at the peripheral utilization. But today I just want to overview these patterns. Okay? And then if you're just jonesing for this information, read Dr. Kharrazian's book, Why Do I Have Thyroid Symptoms Even My Lab Tests Are Normal? And there's a chapter, I think it's chapter 10, that's specifically the patterns that we're talking about. Yeah, chapter 10, the 22 patterns of thyroid dysfunction. Okay? So, without further ado, let's get into this. Now, we can't get into specific lab findings here because it would just be super confusing. And by the way, if you're looking for a practitioner that understands these patterns, this is a book that was written for the public by Dr. Kharrazian. Dr. Kharrazian wrote a 3-day seminar for practitioners. And so Apex Energetics puts on these seminars. And if you're looking for a doctor that understands thyroid physiology, just call Apex Energetics and, ask them, can you tell me somebody that maybe has done your thyroid seminar, and they might be able to help you find that person local. Okay, we definitely do consulting from a distance, but sometimes it's nice to be face-to-face with people, and I certainly want to support other doctors that are learning this information. There are a lot of people that have taken that seminar and taken it many times and master that information, so it's good information to have as a clinician. Okay, so there are 5 things in the literature that will mess with this pattern right here. Okay? 5 things with the brain. Okay? And what this looks like is it looks a lot like if you do your lab test, okay? So if you're looking at thyroid labs right now and your TSH is less than 1.85, then probably you have what's called pituitary dysregulation. Okay, now I just want to overview this. There are products nutritionally that can support the underlying physiology of all of these issues. Okay, but there's one pattern out of these 22 patterns that absolutely requires your prescription, and if a person doesn't get that prescription, it's called primary hypothyroidism, they will suffer. So a lot of people are very naturally biased, and I appreciate that, and they don't want to take drugs, and I appreciate that. However, if you have primary hypothyroidism and you don't take a prescription medicine, it's going to be rough. It's going to be really rough. And I highly recommend that you consider, taking thyroid medicine. If your TSH is really, really, really high and your T4 is really, really, really low, then you might do best with a prescription, okay? So if you have a TSH that's low, less than the functional range, or certainly less than the lab range, it's usually 2 things or 3 things. The first thing it could be you have Graves' disease, okay? Which is an autoimmune condition where you attack TSH or T4 or T3. Now here's the deal. This is gonna start getting really complex, and I wanna try to keep this simple, okay? But if you have really low TSH, what does that probably mean is going on with your thyroid hormones? Are they high or are they low? If the thermostat is like, whoa, it's too hot in the room, let's turn it down, let's lower TSH, it probably means there's too much thyroid hormone, right? So when we see low thyroid hormone or low TSH, then we need to see immediately what's going on with T3 and T4. If T4 is low and TSH is low, it's probably not Graves' disease, right? Because if T4 is low, that means that there's no thyroid hormone being made, and that means the brain should be yelling at the thyroid to make more hormone, okay? So in primary hypothyroidism, which requires prescription medicine in most cases, TSH is really high, okay? High TSH and low T4. That's primary hypothyroidism. That's going to require prescription. Now that's a whole nother story, because I see people that are put on prescriptions for thyroid hormone, and they also have Hashimoto's, which is autoimmunity, and the stuff in the prescription drug actually has gluten in it, or cornstarch, or another chemical like a food coloring that triggers their autoimmunity. So they don't feel better, although their levels start to look better. So they go on their thyroid hormone, and their TSH comes back to normal, but their T4 still looks low. Now their T4 might look low because they're taking Synthroid, which is a synthetic hormone. So do you see how tricky this can be? A person can have drugs in their system that the labs can't even pick up. So it's like, okay, now we're looking at a lab, and there might be something in the lab that we're not seeing, or in the blood. So as a doctor, we have to say, are you on a medication? We have to know if it's bioidentical hormone or if it's synthetic. If it's synthetic, then we have to know that even though this looks low, it might be normal, and that's why this is now looking normal. Do you see how confusing this can get if you don't see this day in and day out, all day, every day? And so that's primary hypothyroidism, okay? That's the one pattern that would most often require medication. Okay, the other pattern that would most often require medication and referral is if TSH is really, really low. If TSH is really, really low, and T4 or T3 is really high. And that means this. Usually in Graves' disease, there's so much damage to this factory that now hormone starts leaking everywhere, and the levels go really, really high. And because the levels are so high, the TSH goes really, really far down, because the brain's like, look, we already have too much. We're at capacity. We need to stop this, okay? And that person often will have a serious crisis if they don't get on the right medicine for that, okay? Now, I often see this. I often see low TSH and high T3 and high T4, but it's not from Graves' disease. It's because they're on a bioidentical hormone and they're being over-medicated. Okay, now, this is an important concept, okay? If you have too much thyroid hormone here, okay, and let's say there's a number of receptors here for thyroid hormone, and your body's getting all the stimulus, they might do this. Hey, we're being overstimulated here. We're going to protect ourselves, or we're going to reduce the amount of receptors we have for thyroid hormone. It's called thyroid hormone resistance, and it's kind of like insulin resistance. You know how people's blood sugar starts to go up and they have insulin resistance? So now they don't respond to insulin and their blood sugar stays in their blood. It doesn't go in their cells. You can have thyroid hormone resistance. So your thyroid's there, it's trying to activate the tissue, but the receptors are just gone because they've been over-medicated. And it can take weeks to months to get them to come back normally. And so that person needs to come off, or I shouldn't say it this way. I would say in that situation, I refer back to their primary care physician so that they can get on the appropriate level of medication so that their body can start to self-regulate. But what happens is as their body repopulates these receptors, they just often feel crappy. They feel depressed, they feel constipated, they feel like they're gaining weight again, they feel worse energy. But in order to get to that next plateau for them, that needs to be done. So a lot of the work that I do when I'm working with people on thyroid medicine is co-managing their prescription with their primary care or finding the right prescription for them, okay? So let me just say this. I'm gonna spend 30 minutes on these 5 patterns up here. So we're gonna do part 2. I'm gonna spend 30 minutes on the 5' duodenase pattern, okay? And then I'm gonna spend 30 minutes on the receptor pattern, okay? But what I wanna say is that on a very simple level, there are supplements that support the brain and support the pituitary gland and support dopamine and serotonin that can help these patterns, okay? there are supplements that can help support people that are deficient in cofactors here. A lot of people that are vegan, for example, aren't getting enough protein, or if they have celiac disease and they have malabsorption, they're not getting enough protein. And so that's why they're not making T4. They have high TSH but low T4, but it's because they're vegan. Okay, so we can't just look at their labs and say, oh, you have high TSH and low T4, that means you have primary hypothyroidism, and for sure you need a prescription. If their history is like, yeah, I just eat a lot of bread and they're a sugartarian, not a vegan, okay, and they don't eat vegetables or they don't supplement with other proteins their body can use, now all of a sudden they become depleted and they have primary hypothyroidism, but it's due to lack of cofactors or building blocks or constituents to make thyroid hormone. So that person may require medication in the short term, but long term, if they get back on the right amount of food for their body or start absorbing or utilizing it better, then maybe they don't need to be on their prescription very long. Okay, so that's one issue. There are patterns associated with free versus bound hormone, and that relates to estrogen and testosterone. So we're going to get into that a little bit when we start talking about 5' deodenase. Okay, there are patterns that relate to this conversion that relate to stress hormone, that relate to immune system activation, that relate to bowel function, that relate to dopamine and serotonin. And so we need to kind of spend a little bit of time and go through each one of those things, okay? And then there are things that happen at the periphery where the receptor just doesn't respond, and it's because the person might not have enough vitamin A. And here's the deal. A lot of people with hypothyroidism have malabsorption. A lot of people with hypothyroidism have celiac disease or gluten sensitivity or a food problem where they have malabsorption. And so they become deficient in all their fat-soluble vitamins, and now their receptors don't respond because they're missing fat-soluble vitamins, and it becomes a vicious cycle. The thyroid hormone gets worse, digestion gets worse, fat absorption and fat-soluble vitamin absorption gets worse, even if they're taking them, and then now it's just this vicious downward spiral, okay? Which is why companies like Apex have developed sublingual products that are like vitamin A that just goes under the tongue rather than through digestion. So it becomes really interesting as a practitioner. We have all these different tools in our toolkit, and sometimes we use vitamin A that just goes through the stomach. Sometimes we want to use vitamin A that's sublingual. Sometimes we want to use vitamin A by itself, and sometimes we want to combine it with other fat-soluble vitamins. And all of that comes back on the history and on the forms and on the labs and on the exam. So it's really the art of being a practitioner that will determine all of that stuff, not some protocol saying I have hypothyroidism, that's receptor-based pathology, and I should for sure go on vitamin A without any thought whatsoever about what type of vitamin A might serve that person. Does that make sense? Okay, so in summary for today, because today is an introduction, there are roughly 22 functional patterns of thyroid disturbance in the literature. So there's 22 checkpoints on this diagram where things can go wrong. And there are nutritional support physiologically that we can do for just about every one of those patterns, including primary hypothyroidism, when there are physiological issues, not just pathological issues that require medicine, okay? And there are protocols out there where a person can do the labs, they can identify the 22 patterns, and then they can do a protocol based on the pattern. And that protocol is awesome, and let me tell you, those protocols help people, okay? But the real work of functional doctors is to say, why do they need this protocol? And sometimes the supplement supports the physiology, but it doesn't support why the person needed the physiology. For example, if the person was deficient in tyrosine because they were vegan, giving them cofactors does not fix the problem, because as soon as they stop the cofactors, they will get sick again. We need to educate the person on to what is going on with them so they can make lifestyle changes accordingly, okay? If the person is not vegan and they have terrible malabsorption or utilization of protein, then we need to identify why do they have a stomach problem or a small intestine problem not allowing them to absorb tyrosine. And for that person, we can give them cofactors, but what if they have malabsorption? What are those cofactors going to actually do? Those cofactors are basically they're going to go out the bowel, or they're going to go out the sweat. They're just going to go out their body. They're not going to be utilized, okay? So my point is that in the next section, we're going to start getting into specifics of each one of these patterns, and we're going to talk about nutritional support for each pattern, the underlying physiological support, and how awesome that is. And then the grand last part of each one of those sections, we're going to talk about some of the things that go wrong that require the need for each of those. Okay? So does anybody have any questions for me that I can answer before I conclude today? Somebody said there's a difference in results from blood testing and saliva testing. So my question would be, were those tests done on the same day? And sometimes saliva testing is testing testing an IgA antibody, and blood testing is testing what's called an IgG antibody. So either the testing wasn't done on the same day and the antibodies can fluctuate, or the person had a saliva test that was negative because they don't have IgA-based antibodies. So think of different colors of paint on the X's, okay? So we talked about the guy comes by and paints the tree with an X, and then the guy comes down and chops it down, another guy. So if the person has one type of antibody that's like red, that means that the city worker did it. All right, if the X on the tree is blue, that means a graffiti person came and did it, and it's not valid, okay? So I'm not saying that a salivary test isn't valid, but I'm just saying there are two different things that are doing it, two different workers. So a person can have a saliva test that's negative and a blood test is positive that way. Okay? Do I take both blood, urine tests when I check thyroid levels? I don't really like, personally, I don't tend to use thyroid urinary tests. And the reason is because blood tests are so good and they're readily available. And the thing about urine tests when they're testing hormones is that urine testing measures the metabolite or the breakdown of that hormone, and it doesn't really tell us what's happening at the level of the tissue necessarily. And it really doesn't tell us what's happening in the blood. It just tells us the liver's capacity to break it down. So a lot of people that I see have a thyroid pattern that's liver-based, and because they have a liver-based thyroid pattern, the accuracy of the metabolites in relationship to what's going on in the blood may not be there. Does that make sense? So I tend to not use urinary testing for that. Okay. What about low thyroid markers across the board? Low TSH, low T3, and low T4. That's a great question, okay? And that's what we're going to get into more. We're going to do, the thing is that's so common, I want to do 30 minutes just on that, but that's called a secondary hypothyroidism, okay? Which means that the thyroid is fine, it's just not getting the signal from the brain because the TSH is low. So it's secondary to a brain issue, okay? Now, we're going to talk about this in more detail next time, but there are 5 main reasons for that in the literature. One is related to cytokine elevation, which are chemicals the immune system uses to speak. So you know how sometimes you get really tired when you're sick, you got the flu, you get tired? Your immune system's freaking out trying to fight off this infection, and they're producing all these chemicals. They're called cytokines to communicate, and one of the things cytokines do is they suppress this area, the hypothalamic pituitary axis, and because of that, TSH goes down, and that's what makes us tired, partially. We'll see there's a couple other mechanisms related to thyroid, but that's part of it, okay? And so another cause of secondary hypothyroidism is high cortisol. So a person has a high stress response, then they'll have low TSH potentially causing low T4 and low T3, and so that's secondary hypothyroidism from high cortisol, which could come from, blood sugar disturbance. It could come from just being really stressed out all the time, from lack of sleep. So then we have to identify that pattern. And again, we'll get into more of that next time. It can be low, TSH can be low because you see this little spot here in the brain, up here? There are projections from other parts of the brain that feed into this. Serotonergic projections and dopaminergic projections, okay? And so if there's a problem in the serotonergic or the dopaminergic projection, meaning the firing of the brain, TSH can be low. So this could be like your left brain dominant person has really good of one projection, but they're not getting a lot of projections from the other system. And because of that, they're getting subtle pituitary dysregularities through the hypothalamus, and they get secondary hypothyroidism from that. And they're not going to respond until they get brain activation to get those things to match. Isn't that awesome? Okay, now how do we figure that out? We have the form in our office called a brain function assessment form that looks at that. We have a form in our office called a brain health nutrition assessment form that looks at dopamine versus serotonin. And I'll tell you that I see so many secondary hypothyroidisms. The majority of hypothyroidisms that I see are autoimmune based and then followed by secondary hypothyroidism. And I'll also say this, the majority of people that I see have several of these patterns. They have like 5 of these patterns at once. And so they go see a doctor to get medicine, but they have a peripheral utilization issue and the thyroid hormone receptor doesn't respond, even though the medicine is getting in the system. Or they have a conversion issue. So they take a synthetic T4 and that T4 doesn't convert to T3, so they're still low on T3 and the T3 doesn't activate the tissue. Can you see it? Can you see how like there's little nuances? But it's really not that, once you get used to it, it's kind of like you start reading the patterns really quickly. So I can look at a lab and I can see the pattern very quickly, and then we can say, this is how we support that pattern nutritionally. Now let's get to the work of understanding the underlying imbalance that caused this pattern to manifest. And that's truly what we do here. Okay, so let me see if there's any other questions here. I'm a hypothyroid with Hashimoto's, but my labs are now normal, no meds. But I worry that these are true results based on what I'm hearing. Okay, so a person with Hashimoto's antibody, or with thyroid antibodies, which would mean this, they're attacking these 2 things here, but the rest of this looks normal. First thing I'd ask is, are they normal based upon this range, or are they normal based on this range? Okay, if they're normal based on this range, then you might have something called euthyroid Hashimoto's, which means you just have the antibodies, but you're not feeling well. And the thing is, when you have antibodies, odds are you have inflammation in your body from immune system function. And even though that inflammation may not be suppressing TSH, that inflammation may be affecting these receptors here. And so now you have a peripheral utilization issue. And so your thyroid hormones look normal. What I'd be very interested in looking at your case would be, I would be interested in looking at your white blood cell count to see if they're functionally low, meaning less than 5, or if they're elevated, or if you're showing any evidence of infection. Because we just talked about how infection can cause low energy by its effect on the thyroid gland. So you can see that there's just a lot of really cool stuff out there. There's a cool way to work on this. Let me answer a couple more questions, then I got to get going. What could be going on if you have low T3 and T4 and TSH of 5, but taking thyroid hormone or a hormone causes severe headache? That's a good question. TSH of 5 would suggest that the brain is wanting more thyroid hormone, and low T3 and T4 would suggest that there's an output. My question would be, what is the thyroid hormone? Because if it's a synthetic hormone, it may not be registering, so the thyroid hormone might not actually be low. Okay, and this product she's talking about that supports the pituitary gland, actually thyroxyl supports cofactors. So basically what she's saying is, look, I have low hormones and I have high TSH, but taking the hormones isn't doing it, and taking the nutritional support isn't doing it. Well, you might have several other patterns going on, and taking the thyroid hormone actually is somehow exceeding your metabolic rate. Taking the supplement might be exceeding your metabolic rate. Some people react to drugs that they're taking. And again, I'm not telling you not to take your drug at all. I'm not saying that. But I'm saying that some people that take prescriptions get headaches after they start taking their prescription. And if you look at the side effects of the drug on that giant accordion sheet that they gave you, if it says headaches as a side effect, then that might be part of what's going on. And there are ways to deduce what the underlying mechanism is there. It's more than we can get into here. What about high TSH, high T3 free, average T4 3 with less than 1 of a binding globulin? So that person has normal here. That person has a high TSH and a high T3 with an average T4 free. So that's not a complete pattern. The thyroid may not be responding to free hormones. The thyroid might be only responding to bound hormones. So you measured this, and this, but you didn't measure any of these. So without knowing what's going on with your total levels, Ms. Summer, we're not going to know the answer to that question. Okay, so a great panel that I like to order, just to kind of summarize a nice panel, LabCorp does a panel through a lab that we work with called Principal Lab, a conglomerate of LabCorp, and it's like $100 to measure all those patterns. Okay, and so we could at least identify what's going on this map of 22 patterns. It won't necessarily tell us the underlying physiological process that caused those patterns to emerge, but at least gives us a starting point. Okay, so I know I said I was going to be half hour. I'm way over time. So for those of you that stuck around, I really appreciate it. And please share this with people that you know that just are fatigued, have an issue they're not getting over, have thyroid issues, and they've been told that they're just crazy or they're getting old. They better get used to it. It's just life. Just deal with it. Because, you know, maybe it is just life for some of those people, but maybe they have a pattern here that's absolutely something that we can identify and help them remediate so their quality of life improves. And, you know, they can live freely and they can prosper. Okay, thank you for your time. And I'll be posting when we do part 2 of this, probably sometime next week. Bye.